Good morning. I want to thank the organizers. I want to thank the panel, Mr. Conway, Dr. Paul. I'm from Brooklyn. It's great to know AAKP started in Brooklyn. I trained at Kings County Hospital, and I want to thank Dominic Raj so much for putting this together and bringing me here. You know, this is about global innovations, and I can't think about anything more innovative in medicine, much less nephrology, than discovery of a genetic cause for 1/3 of all the end-stage renal disease in the African-American population and populations with recent African ancestry, by which we mean people that currently live on the continent of Africa. So I'm here to talk today about that big breakthrough, the APOL1 gene and the NIH Apollo study, which will bring it into practice. The big green button is what you should hit for the speakers, the big green button. Okay, thank you. Here's my disclosures. So this is what it's all about. It's about this patient who, I've seen patients just like her when I trained in New York, in North Carolina, here in DC. If you go to any city in the United States, this is a young African-American woman. She's thin. Does not have diabetes. She has very little protein in her urine, and she goes to the doctor in her late 30s, early 40s, has mild kidney disease. They tell her, well, don't worry, your blood pressure's up, it's hypertensive kidney disease, I'll put you on this blood pressure medicine, you'll be fine. And about 10 years later, she's on dialysis because lowering the blood pressure did not cure her disease. And I'm just here to tell you what started me on this mission was patients like her who had many members of their family also on dialysis saying, Dr. Freedman, it's not about my blood pressure, there's something in my family. And about 1/3 of African Americans starting dialysis are labeled as having hypertensive kidney disease. About 1/4 of white patients on dialysis are labeled as that. And we've been pushing to reclassify the causes of kidney disease in the USRDS and in registries around the world because they're incorrect and they really impede breakthroughs that will lead to treatment. What I can tell you now is if you look at this curve of the new start rate for end-stage renal disease in the United States, years ago we used to look at African Americans, Asian Americans, American Indians, and Caucasians on the bottom and say, well, there must be genetic differences, environmental differences that lead to these markedly different rates of end-stage renal disease. But with improvements in medical care, nearly every ancestral population is clustered around 300 cases of end-stage renal disease per million population per year, except African Americans. And the vast majority of that excess risk for kidney disease in African Americans relates to this single gene. 2 changes in the gene. And it's a fascinating story. And it all started with family clustering of kidney disease. That's what really brought this to our attention. This is a publication from our group a long time ago, early 90s, where these are families, and they all have somebody with an A, just like the patient I showed you on dialysis, non-diabetic, thin, very little protein in the urine, thought to have hypertensive kidney disease. But the fact is that they have other relatives with end-stage renal disease in their families from HIV, focal segmental glomerulosclerosis, lupus, sickle cell disease. It was not one cause of kidney disease. And we hypothesized that these cases didn't have hypertensive kidney disease, but there was a single overarching gene in these families, in African-American families, that predisposed to end-stage renal disease. And it took about 25 years and lots of DNA sample collections and breakthroughs in genetic technologies that led to this landmark paper that we were fortunate to work on with Martin Pollack's group and Jeffrey Kopp's group. And this is association of the APOL1 gene with end-stage renal disease in African Americans. And it turned out that it was a selection process where people who had one copy of the change in this gene, which we used to call a mutation, now we'd call it a variant because they're so common. It's not a single mutation, it's spread throughout the world, or the African population throughout the world. And if you have one copy, you're protected from this parasite, Trypanosoma brucei, a cause of African sleeping sickness. And I want you to see, if you take blood from somebody with one of the risk variants, it kills the trypanosome. But if you take blood from an African person who doesn't have the kidney variants, the trypanosome lives well. So it turned out with these changes in the gene, people were protected from an early death from African sleeping sickness, multiplied, passed the protective effect on. But if you got 2 copies of the risk variant in this gene, one from your mother, one from your father, your risk for kidney disease goes up astronomically. And in fact, this is the same story as sickle cell disease. One copy of the sickle cell gene is protective from malaria, so the frequencies went up relatively high because people survived malaria. If you get two copies, one from your mom, one from your dad, you get very sick with sickle cell disease. It's a very similar relationship. And in fact, in Africa, this Trypanosoma brucei rhodesiensis parasite is carried by the tsetse fly, and you get stung by the tsetse fly. There's a canker sore on the leg of a young African woman who's been stung, transmitting the parasite. If you had a mutation in this gene, APOL1, which only came about less than 10,000 years ago, you were more likely to survive this and pass the gene on. So it's an amazing story. Now, people have been studying animal models of kidney disease, and all my grants were rejected for years because people had rat models and this model and that model. And the fact is the APOL1 gene is only found in humans and a couple of higher level primates. It's not in rodents. It's not in other animals. You can't find it there. It's a different disease. And if you take, if you take one of these animals that does not have the APOL1 gene and insert the kidney disease variants, they get kidney disease. And if you insert the normal variant that doesn't cause kidney disease, they're protected. So now, this is not just an association. This is not one of those reports that's going to come and go. This is the gene that causes kidney disease. And when you give it to an animal that doesn't have it, they develop kidney disease as well. So a big breakthrough. And in fact, it's the strongest genetic association in any common complex human disease. It just happens to be in kidney disease nephrology. What's striking to me is that we all talk about sickle cell disease. About 8% of the African American population has one or two copies of the sickle gene. You know, the vast majority, 7.8% or so, have one copy. 0.2% have two copies. The changes in APOL1 are recent. They came about less than 10,000 years ago. But I want you to know that in the United States, 13% of all African Americans, more than 5 million people, have two risk variants, one from their mother, one from their father. 20% of them will go on and get kidney disease. Another 39% have one copy. So if you add that together, more than half of the African American population carries one or two risk variants in this gene, as opposed to 8% of sickle cell disease. These risk variants are virtually absent in all other populations, European, Asian, Hispanic. When you read papers about APOL1 in Hispanic populations in New York, it's because of admixture of Dominican and Puerto Rican populations with African populations. The APOL1 gene comes from Africa, so it's not really a Hispanic variant. What's interesting is that the risk of getting diseases like focal segmental glomerulosclerosis and HIV-associated nephropathy associated with this gene, the population attributable risk is 70%. What that means, in simple terms, is if these two changes in the gene didn't come about 10,000 years ago, 70% of all cases of FSGS and HIV-associated nephropathy in the United States disappear. And basically, the rates of non-diabetic kidney disease in blacks and whites would be the same. It's a striking, striking finding. And it's only found in humans, gorillas, and baboons. So every other animal model that was funded ahead of all my grants to the NIH, couldn't have found this gene. What's really exciting is I'm about to tell you about the Apollo study where we're going to use it and change practice. But there's actually an antisense oligonucleotide, a way to block this gene with a biological that's being developed by a large company and is very exciting for a cure for this disease. A third of all end-stage renal disease in African Americans could go away with a cure. And the spectrum of diseases associated with it, the disease we used to call hypertensive nephrosclerosis, now I call it hypertension-attributed nephropathy. People attribute it to hypertension. It's really solidified glomerulosclerosis. It's in the family of focal segmental glomerulosclerosis, HIV-associated nephropathy or collapsing forms of glomerulosclerosis, sickle cell disease, severe lupus nephritis, and failure of kidneys donated that are then transplanted. That's all part of the spectrum. And I just want you to see these numbers. These are odds ratios for association. These are off the map. I mean, these are like Mendelian diseases. It's never been seen before in common disease. So APOL1 causes about a third of end-stage renal disease in African Americans, contributes to the higher risk of non-diabetic kidney disease in blacks compared to whites, the poorer outcome in lupus nephritis in African American patients, and the shorter kidney transplant survival. And I'm here today to talk about the Apollo study, the APOL1 long-term kidney transplantation outcomes network funded by the NIDDK. Dr. Paul Kimmel, our program officer, is in the audience, and it was his vision and foresight that helped form the study. I can tell you that testing for this gene is now employed by many kidney transplant programs to assess the safety of living donation from African American populations, especially those who have family members on dialysis. The Apollo Consortium is assessing the role of APOL1 not only in living donors, but also in deceased donor kidneys from African American donors. And we think that the results of Apollo will better define the quality of the donor organ, changing the way organs are allocated. It's going to improve matching of donor kidneys with recipients, leading to longer function. Most importantly, it's going to reduce the discard rate of very good quality kidneys, and you'll be shocked at the data I show you in a minute. That will lead to more transplants, and of course, I think it will improve safety of living donation. So that's what Apollo's mission is, and it's based on this fact. This is deceased donor kidney transplantation, where it's known for a long time that kidney donors of African ancestry or African Americans, those kidneys don't function for as long after they're transplanted in a recipient as do kidneys from donors of other ancestral populations. It doesn't matter if you're a white or a black or an Asian recipient. It matters the donor ancestry. Well, nobody knew why, just like African Americans get more end-stage renal disease, why do their kidneys not do as well until this paper was published by our group. The gene was discovered in 2010. This is a 2011 paper where we showed that in a single center at Wake Forest, these are all African American deceased donor kidney transplants. These are the group who had APOL1 risk genotypes, 2 copies of APOL1, and look, at 2 to 3 years, half of them had failed. But if you got a kidney transplant from an African American who didn't have 2 copies of APOL1, in fact, those kidneys do just as well as kidneys donated by European Americans. And the kidneys that failed in this group were not failing from rejection. They were failing from APOL1-associated kidney disease. But, you know, single center study, a lot of people had a lot invested in how kidneys were allocated. They poo-pooed it. So we had to keep coming back. We got together with groups at UAB, Emory, more kidneys from Wake Forest, and we looked at 1,153 deceased donor kidney transplants from more than 624 donors at 113 different transplant programs. And you see the same thing. These are all African American deceased donor transplants. The kidneys that came from donors with 2 risk variants were twice as likely to fail at 6 years than the kidneys came from an African American donor without. So the first point I want to make, it's not about African American kidneys and African American donation. It's about a gene variant that just happens to be more common in African American populations. This is a genetic disorder. It's got nothing to do really with race or ancestry or anything like that. It's genetics. The second point I want to make is when we showed this data to all the transplant physicians who believe in things that donor age is important, sensitization, panel reactive antibodies, recipient age, HLA matching, cold ischemia time, standard versus expanded criteria donation. That's the stuff that they're testing for and they believe in. When you put APOL1 in the model, you can see APOL1 had a bigger effect than all of those other factors and a lower p-value at the same time as those things were being considered. So APOL1 is a very powerful determinant of kidney transplant outcomes, at least as powerful as all the stuff that transplant physicians are using today. And that's what led to Apollo. Because right now, there's a new kidney allocation system for how deceased donor kidneys are given out. And the big problem that's faced in transplantation is young, healthy people need good quality kidneys so their kidneys can last for their lifetime. And older, sicker folks can get a lesser quality kidney because they're more likely to die of a heart attack or stroke and not have a 25, 30-year survival. They're going to go before the kidney goes. And what was happening is really good quality kidneys were going to older, sicker patients, and those patients were dying with functioning kidneys. So what this system tries to do is guess the quality of that kidney, and it looks at 10 factors: age, height, weight. But look, it looks at ethnicity. If you're an African American donor of that kidney, it's downgraded because of that old data showing African American donor kidneys fail more quickly. Well, it turns out only 13% of African Americans have 2 APOL1 risk variants. 87% of them don't have it. Every transplant is downgraded. So working with Bruce Julian and others at UAB, we published a paper about what would happen if you took black race out, or African American ethnicity out, and you used APOL1 genotype. And the data are shocking. This is why there's an Apollo study. Remember I showed you the 1,150 transplants we did, that study at 6-year follow-up? They were twice as likely to fail in a high-risk donor. Well, this is the data from those same 1,150 transplants. And in the current era, whether the donor has a low-risk genotype, 0 or 1 kidney variants in APOL1, or a high-risk
genotype, these are the guys that are more likely to get kidney failure in their lifetime, their kidney donor risk index was the same, about 1.49, 1.47. And those kidneys would do worse than about 70% of all the kidneys transplanted the year before using the current allocation system. But we replaced the current allocation system with APOL1. And I just want you to see, the low-risk group, they don't do worse than 71% of transplants. They're perfectly average. They do as well as half the kidneys in the nation. But if you got one of those kidneys from a high-risk donor, they don't do worse than 70%. They do worse than almost 90%. These are the high-risk kidneys. These are low-risk kidneys. They're all being treated the same. Why is that important? Because 85% of the time, the African-American donor kidney is perfectly good quality. Only about 15% of the time are they being downgraded because they have two risk variants. Well, these kidneys can be used and transplanted into older, sicker patients. These kidneys are perfectly good and could go into younger, healthier patients. Kidneys are being discarded because of the wrong KDPI based on just race when it should be based on biology and APOL1 genotype. So we think that the Apollo study will really improve the outcomes of deceased donor transplantation, reduce discard, more people will get kidney, it will help all of society. What about safety of living donors? And this is a paper by Mona Doshi and Emilio Paggio, Jeffrey Kopp. These guys are in Apollo with us. They looked at 136 African-American living kidney donors based on APOL1, and very quickly, 19 of the 136 had a high-risk genotype, 117 had a low-risk genotype, and the kidney function, the glomerular filtration rate, at the time of donation was normal in both groups, but it was significantly higher in the low-risk group, 108 versus 98 in the high-risk group. The creatinines are 0.89 and 0.98. So although they all kind of look normal, when you break them out by APOL1, the high-risk group look like they have less kidney function. But what happened after donation 12 years later? I want you to know these are 19 people that gave up a kidney to a loved one and were thought to be perfectly healthy. 12 years later, 2 of the 19, or 11%, were on dialysis in the high-risk group. There were 117 living donors in the low-risk group. None of them were on dialysis. The other point is, what percent of them had kidney function less than 60%? 32% of the low-risk group had kidney function at GFR less than 60 12 years later. 36%. But in the high-risk group, 2/3 had kidney function below 60%. So they were on their way to getting more kidney disease. So, you know, a lot of centers are testing African-American living donors, and if they have a high-risk genotype, counseling them and saying maybe it's not safe. So people take this as a terrible thing. The number of living donors is going down in the nation. The number of African-American living donors is going down even more. This is a great thing. If you can tell the people who are at risk and safely remove them from the population, other African Americans are going to feel much better about donating. We think this is going to increase living donation in the African American population. African Americans have more end-stage renal disease after donating than any other ancestral population. So we think this will actually improve post-donation. And I'm going to stop there and tell you we've got a great collaborative team, and we're very excited about Apollo. But in the spirit of this meeting for basically moving science forward, the APOL1 finding will lead to a cure for 1/3 of end-stage renal disease in African Americans and improve transplantation outcomes. Thank you.